Hello, everyone. Thank you for joining us today for our webinar on the HOPE assessment tool. We know this is very timely and a topic everyone is interested in learning more about, so we really appreciate you all joining us today. Just a couple of logistical items to cover. This meeting is going to be recorded, and the recording will be available to anyone who registered after the event has closed. You will get an automatic email that the recording is available for your review. We also have some resources that have been posted in the chat. We will not be using the chat during the presentation, but those resources will be available to you through the chat. We do ask that any questions you have be posted in the Q&A, and then we will address those at the end of the presentation during the Q&A section. Thank you very much. I'm going to turn it over to our presenters today, to Jennifer Kennedy and Kimberly Skehan, so they can introduce themselves and take on this topic.
Great. Thank you so much, Denise. And thank you, everyone, for carving some time out of your day to learn about the HOPE assessment. I'm Jennifer Kennedy. I am the Vice President for Quality Standards and Compliance at CHAP. And Kim?
Hi, everyone. And yes, thanks for joining us. I'm Kim Skehan. I am the Vice President for Accreditation for CHAP.
All right. Well, now that we know who is who, let's go ahead and start the show. So today, what we're going to do for you is describe the implementation of the HOPE assessment tool, and then we'll also discuss some of the content highlights and their impact on hospice program implementations in the future. So HOPE started many years ago, or actually the idea of it, and developing a draft tool for testing. It went through pilot testing and then alpha testing and then beta testing. But the overarching goals have remained the same, that it would be a vehicle for CMS to use to develop a standardized data collection, which would then have clinical data or patient level data that could inform future quality measurement development for the hospice quality reporting program, and also that it would provide information and data for future payment refinement. Some additional objectives of the HOPE tool is that it will give information to help additional QAPI initiatives that CMS will develop as time progresses. It does include an interdisciplinary approach in the assessment process, again, that will help inform future measure development. It is designed to help the hospice team with care planning, and it does align with conditions of participation. So we can't talk about the HOPE tool unless we mention the final fiscal year 2025 payment update rule very briefly, which I've given you the link here to the Federal Register. That rule posted on August 6, 2024, and basically contained all of the information about the whole implementation. So we are a go. The go date is October 1, 2025. That is when HOPE data collection begins. And then public reporting is scheduled to begin no earlier than calendar year 2028. And that would be public reporting for the first two HOPE-related quality measures. And more information will unfold about these measures as the HOPE gets going and data is collected to support public reporting for those measures. CMS will have that data by collecting the first several quarters of data to validate the soundness of the quality measures and make sure that they are valid and reliable. So the implementation will coordinate with the fiscal year 2028 payment adjustment. Now, I mentioned just a moment ago that There are no changes with the conditions of participation. And that was done on purpose. So your requirement at 418.54 comprehensive assessment remains the same. The content remains the same. There are some overlapping areas with the content in this COP and the HOPE data collection. So it is going to be really important for you to check in with your electronic medical record vendor that none of the items that are required at 418.54 drop out while they are building the HOPE assessment tool into your EMR. When we're looking at some of the content or requirements of the HOPE, you need to, as a hospice provider, submit the standardized HOPE assessment for each patient, and that's all of the items included in that assessment at the time points, and we'll talk about those in just a little bit, in order for CMS to capture that patient level data. And it's going to be regardless of payer or patient age. The HOPE tool will replace the hospice item set or the HIS upon implementation. So the last day that you're going to do HIS for your patients is September 30th, 2025. The first date that you're going to start your HOPE data collection is October 1, 2025. CMS feels that having a standardized tool will help better collect patient level data during the entire breadth of the hospice stay. And that will help support data in the 2 quality measures that are already developed and quality measures yet to come. The HOPE version 1 contains demographic information, record processing, and patient level standardized data elements. And while those HOPE data elements contribute to the assessment, they do not replace a thorough and ongoing comprehensive assessment of each patient, or they do not replace clinical practice and clinical judgment. All of that is in tandem with you answering each item for each patient in that HOPE assessment. There are specific domains that the HOPE fulfills. It includes a socio-demographic domain, which has been updated to be a little more robust than the current HIS. The diagnosis domain has also been expanded. There is a new symptom impact assessment domain, and imminent death does remain. Data elements that represent other domains are such things as administrative data, preferences of the patient for routine activity and advanced care directives, etc., active diagnoses, health conditions, medications, and something new is skin conditions. And Kim's going to talk to us about that when we get to that section. So public reporting, I did mention that. That means that the data from the measures that you're currently collecting data for and will continue for at least the CAPS measures will continue to be reported on Medicare Care Compare, but the 2 new data quality measures from the HOPE, CMS finalized its decision not to use data from at least that first quarter of 2025, because as I mentioned, they're going to be assessing validity and reliability of the data collection and that impact on those measures. CMS will assess the quality and completeness of the data by the end of Q4 of 2025 before they even think about publicly reporting measures out. So data collected by you, the hospice, during the 4 quarters of calendar year 2026 will be analyzed in calendar year 2027 to see if it's going to be ready for public reporting in fiscal year 2028. So CMS stated in that final rule that they will keep the public updated about decisions, whether to report some of the quality measures or all of the quality measures, or they'll basically tell us what they've decided to report based on that analysis of data of calendar 2026. Yay, CMS has posted data collection specifications, which I'm sure your EMR vendor as soon as they saw that announcement, they have been cheering. So at the time of implementation, all of the HOPE records are going to need to be submitted in an XML file, and that's the same that you're doing for HIS. CMS will have a call with software developers, and they have set up some training for developers, and the draft specifications have now been posted. And CMS will respond to questions, comments, and suggestions from, I'm sure, hospice providers as well as EMR vendors as they unfold. So CMS said that right back in the beginning of the proposed rule last March, that software developers should not wait until the final technical specifications were posted to begin development of their products. Why I'm mentioning this is that hopefully your EMR vendor had started their process based on the information provided by CMS, draft manual, etc., to start building the HOPE tool. So now that we have the final specifications posted, this is a good time for you to check in with your software developer to see how things are going. And I would recommend that you continuously check in with them over the end of this year into the next year to see how the build is going, to see when testing is going to happen with that software vendor. All of those things are going to help you build your timeline for implementation in your organization. CMS will be retiring the hospice abstraction reporting tool, or the HARP. They will no longer provide this free tool for standardized data collection once the HOPE is implemented. We did see some information posted recently about HOPE resources. The guidance manual, or the final guidance manual, is now up. It's been up for maybe about a month now. So if you haven't taken a peek at that, this is the time where you're going in and making sure that you're reviewing all of the information in that final manual. There is also a data collection time points explainer video at the link provided there in the Training and Education Library and the HQRP webpage. And also recently, CMS did post the HOPE Tool web-based training. And this is all on demand, introducing hospice outcomes and patient evaluation, or the HOPE Tool. And there are various sections that are included. I want to say maybe 7 sections included in that web-based training. So it would be advantageous for you to go to that website right now, Training and Education, and look at how you're going to divvy up or make a schedule or have a deadline requirement of who needs to go through that training for HOPE. Now, there is compliance attached to the HOPE assessment tool, and the compliance threshold for HOPE is 90%, which is the current HIS threshold. And that applies to submission, and you see I have in parentheses, and acceptance of each record that you're submitting to CMS. So there are various record types. There's an admission record, a HOPE update visit record, and a discharge record that needs to be submitted for each patient. And it's actually up to 2 hospice update visit records that could be submitted for each patient. If you do not meet the threshold or no data is submitted, then you can expect a 4% payment deduction in the coordinating annual payment update year. So we are still in a pay for reporting system. But if you, for some reason, you don't make your 90% threshold or you choose to abstain from sending any data, then you can expect a 4% payment deduction on a coordinating APU year. There are some general conventions of the tool. All Medicare certified hospice providers are required to submit data. HOPE data are collected during the hospice's routine clinical assessment visits and is based on the unique patient assessment outcomes of that visit. Not all HOPE items are completed at every time point, and we'll review the time points with you in just a moment. All completed HOPE records must be electronically submitted to CMS, similar to what you're doing now. Data is collected and accepted based on in-person visits. So there is no telehealth or any sort of telemedicine or telehealth built into data collection for the HOPE. All data items have to be completed, so you can't miss items. They can't be partially completed. They have to be comprehensively completed. And the hospice quality reporting is at the CCN level. So if you are a hospice that also has a multiple location, but that is still under your parent CCN, you're collecting for the entire CCN. All right, so now I'm going to go ahead and turn the floor over to my colleague, Kim, and she's going to talk to you a little bit about the nuts and bolts of the HOPE assessment tool. Take it away, Kim.
Thanks, Jennifer. Hello, everyone. And I just wanted to say, from two seasoned hospice nurses to many of you who are also seasoned and many who are new, this is an evolution, as we have seen over the past many years, both from the inception of the hospice benefit, the updates to the COPs in 2018, hospice quality reporting implementation, Appendix M changes, all of these changes that have occurred. This is another chapter, if you will, one that we know has been a long time coming. CMS has certainly been in testing for quite some time with many of you as participants. So we are presenting the information with the guidance that we have at this point in time, based on the information that Jennifer has shared. Just knowing that it really is important for you to continue to receive additional education, seek out CMS resources, review the FAQs, the frequently asked questions, as this process evolves. As we speak even today, you'll see where we have identified where there are some, adjustments even since the HOPE tool was first announced, even back in August. So we're going to talk about that a little bit more. Next slide, please. Jennifer, thank you. So just looking at some conventional guidance here. The completion of HOPE records applies to all patient admissions to a Medicare certified hospice program, regardless of the payer source, the patient's age, where the patient receives hospice services. In other words, if they're in a home, nursing home, assisted living, freestanding hospice, or any other setting. And it also does not take into account hospice length of stay. The requirements are still in effect. Next slide, please. So regarding the administration time points, the HOPE admission data is collected as part of the comprehensive assessment of the patient, no later than 5 calendar days after the effective date of the hospice election. We know this, it's in accordance with the current condition of participation. The update visit is collected, as Jennifer said, via in-person visits to inform updates to the plan of care. Up to 2 hospice update, HOPE update visits may be recorded or required for every patient admission, depending on the length of stay. And CMS will only accept 2 HUV assessments. So what that means is, if a patient is on service for essentially more than 30 days or up to 30 days, you will have both of those HUV visits. But if you have a shorter length of stay, you would not have those visits. We'll talk more about additional time points as well. Since the data collected for these visits do include data that require skilled nursing assessment, it's generally expected that the RN would be completing these visits. And actually, if you review the most recent webinar training that was released on October 1st, on the CMS website, in the FAQs, it does indicate that it is expected that the RN will complete the assessment component of the admission and the HUV assessment, but that an LPN or LVN can complete the symptom follow-up visit. So we'll talk about that again in just a moment. Next slide, please. So discharge is collected at the time of discharge, and the HOPE records should be submitted even if the patient revokes the hospice benefit or is discharged from the hospice before all HOPE-related care processes are complete. And there are some allowable discharge reasons, which are listed here, as well as also in the HOPE user manual. And they include death, revocation, no longer terminally ill, moved out of the hospice provider service area, transferred to another hospice, or discharged for cause. And again, there is detailed guidance and scenarios for admissions and the need to complete a HUV visit in the HOPE guidance manual. So make sure that you review the manual as well as all of the trainings. Next slide, please. This is a slide, again, from CMS training that outlines the HOPE administration time points. And you can see that the comprehensive assessment and the admission HOPE data is completed from the time of admission, the first 5 days following admission, in alignment with the comprehensive assessment. The HUV or the HOPE update visit 1, the first visit would be completed between days 6 and 15. And then the HOPE update visit 2 would be completed between days 16 and days 30. So somewhere in those time periods, those assessments would be completed. And then the discharge is completed at the time of discharge. Can you show the next slide, please? We're going to talk about the symptom follow-up visit, and then there is a calendar, a grid in this presentation that I will go over as an example as well. The symptom follow-up visit is an in-person visit expected within 2 calendar days as a follow-up for any pain or non-pain symptom impact rated as a moderate to severe in the health conditions section of the HOPE assessment tool. It must be a separate visit from the admission or the HUV visit. So to be clear, you may have a patient who on an admission visit or a HUV visit is rated as severe with a symptom impact of severe for pain, and your hospice may choose to make a follow-up visit not within 2 days. They may choose to make that visit within 1 day or even later that same day, but it is a separate visit, is a separate assessment that must be completed, even if it's completed in the same calendar day. So that is really up to your agency, your hospice, in terms of how frequently or how soon you can demonstrate timely identification and assessment, follow-up, and intervention for any symptom-related issues. It may occur, as I said, anytime within the 2 calendar days. During the admission or HUV visit, the data collected for the symptom impact item may trigger the need for the symptom follow-up visit. They are only required when there is moderate or severe symptoms that are documented on either the admission or one of the HUV time points. And up to three symptom follow-up visits may be required over the course of the hospice stay. Again, in alignment with the admission and the 2 HUV visits. The HOPE symptom follow-up visit is based on that, again, symptom impact, as opposed to the severity rating of the experienced pain or non-pain symptom. It is not an assessment of the severity, intensity, frequency, or other characteristics of the symptom, but rather the impact these symptoms have on the patient. And CMS does define symptom impact as the effect of symptoms on the patient. Symptoms may impact a patient in multiple ways, such as in interrupting their sleep or their concentration or their ability to perform ADLs or movement. And this is an indication that, again, in the FAQs, that CMS has specified that the symptom focus follow-up visit may be completed by either an RN or an LPN or LVM. So I know I say symptom focus visit, but it's symptom follow-up visit. Next slide, please. Okay, this is an example, again, where a moderate or severe symptom is identified or documented. And then if it's scored as moderate or severe, then you would ensure that a symptom follow-up visit is required within those 2 calendar days. If there's no moderate or severe symptoms that were documented with the admission or HUV visits, then there would be no need for a symptom follow-up visit. And it's important to understand that this is CMS's way of, again, evaluating the impact of our follow-up and ability to address these symptoms as we look to future quality reporting measures. This is the chart that I was looking at, the calendar. And you can see that this is an example where the patient was admitted on the first. The RN conducted the initial visit, and there would have been an identified, if there was an identified symptom impact, a symptom follow-up visit was completed. Then they completed a regular nursing visit. Then you open the window, the HUV window for the first HUV visit, and that was completed on the 12th. And again, there was an additional nursing visit. And then the second HUV visit by the RN later in the month with apparently additional symptom impact, symptom impact documentation of moderate or severe, which required a symptom follow-up visit. And then the patient died on the 28th, which resulted in a discharge hope assessment. If the patient had died during day 7, for example, or on day 7, there may only have been an admission and then a discharge, because the HUV visit, the first HUV visit, may not have been completed in the required time frame, and because it's not required except for days 6 to 15. And then also in that case, there may not have been a need for a symptom follow-up visit. It's important to understand that the documentation is multidisciplinary or interdisciplinary, as it is with the HIS. So there may be aspects that are completed or evaluated, such as spiritual preferences, depending on your organization's process. CMS defines the requirement for completion of the data elements in accordance with the COPs as it's related to qualified staff. However, again, in the FAQs, it was clear that the assessments that need to be completed by the RN for the skilled assessment component, but for the admission and the 2 HUV visits, but the symptom follow-up visits can be completed by an RN or an LPN. As Jennifer said, these are nursing centric, so this is what the requirement is at this point in time. I would also add that there is no instruction or guidance regarding physicians or nurse practitioners not acting in the scope of the RN. It would be presumed that the physician is not included in this instruction. That may come out in further guidance. And then the APRN would be functioning as the RN. Next, please. So that's just an area where we're going to want to continue to have some additional guidance and clarity as the HOPE assessment tool is rolled out. If there are administrative discharges, so in other words, a patient remains under hospice care with no interruption in hospice care, a discharge record is not required. For example, if there are changes in payer source or failure to meet the timely face-to-face requirement. If a patient transfers from one hospice to another provider and the two hospices have different CCNs, then each hospice would complete a hospice admission, an update record, visit record if applicable, and the discharge record. And the time points may be required and expected. The HUV time points may be required and expected from either hospice based on that hospice's admission date. Next. Now, when a patient travels, there are a couple of scenarios that are outlined in the user manual. One is managing when the managing home hospice provider discharges the patient for leaving the service area. For example, a patient who has children in 2 different states. Then in that case, they may choose to discharge the patient from one, when they're traveling from one to the next, discharge and then have the patient admitted by the receiving hospice. However, there are occasions where the managing home hospice provider contracts with another hospice provider in the travel area. In that case, no HOPE admission or discharge record is completed because, again, they are serving the patient under the contract with the managing hospice provider. Next. Okay, so we're going to go over the HOPE tool sections briefly as over the next several slides. As Jennifer pointed out, there are the sections include these areas, including administrative information, preferences, active diagnoses, health conditions, new area of skin conditions, medications, and record administration. The administrative information has some changes, not many significant changes, except to add the type of HOPE record admission. So the 4 time points where HOPE may be completed. But many of the other questions are very similar to what we see with the current hospice item set. Next. Preferences as well. Also, there are no changes to this section than what is currently collected in the hospice item set. And you want to make sure in these cases, each section, that again, you refer to the user manual and the detailed training for examples on what constitutes the types of questions and what constitutes specific assessment answers as well, which is very, very helpful. Next slide. This is just an example of the additional, preferences, the life-sustaining treatment preferences, hospitalization, spiritual, existential concerns. And remember, this information either needs to be received through patient interview and assessment and in-person visit, or in the clinical record documentation. Next. Active diagnoses. This is an area for principal diagnoses is still in place as in HIS. However, this section is expanded from 3 three options or three possibilities to 10. So there are 10 areas that you can check or specific diagnostic categories that you can check. 1 of 10 for the principal diagnosis. And again, this is the diagnosis that most contributes to the patient's life expectancy of 6 months or less if the illness runs its normal course at the time of admission. And again, it must be completed based on what is indicated in the clinical record. There is a comorbidity section that refers to the diseases or medical conditions that occur simultaneously with the principal diagnosis, and this includes your comorbidities and or coexisting conditions. So you want to ensure that as an organization, you have that process to ensure to review the medical record for any comorbidities, as well as checking all disease or medical conditions that are addressed in the plan of care or that have the potential to impact the plan of care, both referenced as applicable in the HOPE tool, but also in your assessment and your care planning. Next. Health conditions. The items, again, in this section, there are several new items, and there was one minor edit to the current HIS language, but the items in this section are intended to document the physical symptoms and the impact of pain and non-pain symptoms on the patient, and incorporates, again, the information from the interview with the patient and the family and caregiver, as well as the clinical assessment and judgment of the assessing nurse if the patient's unable to participate. These items do include an assessment of imminent death, screening for pain, comprehensive pain assessment if warranted, and screening for dyspnea. Pain and dyspnea include screenings and assessments that are similar to the hospice item set. You must indicate on the HOPE tool the type of standardized symptom assessment assessment tool that you've used. Next. And the symptom reassessment, again, we talked about this. This is the new, this is where we need to make sure that we're looking at the symptom reassessment to impact whether or evaluate whether a symptom follow-up visit is required. The time points, again, are completed admission or during one of the 2 HOPE update visits. And it's, again, the visit is to the idea of the symptom follow-up visit, and it would be in response to an evaluation of the patient's impact regarding symptoms. Again, it's not a symptom, an assessment of the severity, intensity, frequency, or other characteristics of the symptoms listed, but the impact these symptoms do have on the patient. And it is from this scoring and this assessment that the determination of whether a symptom follow-up visit is warranted. And again, unlike the other assessments, this item may be completed by either an RN or an LPN. Next. Again, we've talked about this, that the symptom reassessment is the symptom follow-up visit and reassessment is a follow-up for moderate to severe symptoms. And each symptom code, for each symptom, a code is entered that describes how the patient has been affected. I want to say that we don't have a screenshot in this webinar, but look at the user manual, because in the user manual and the screenshots, you can see the detail that is required for the system, the symptom reassessment assessment impact, and you can see how the scoring would entail as to what and determine whether or not a symptom follow-up visit is required. But again, if there is a documentation of moderate or severe symptoms or symptom impact, then you would want to schedule a symptom follow-up visit. Next. Skin conditions is a brand new section. The items in this section are here to document the presence, type, and current treatments of various skin conditions common in the hospice patient population. Skin conditions, wounds, and lesions affect the quality of life for patients because they may limit activity and be painful. And these items identify patients at risk for further complications or skin injury. So there are 3 new overall items. This is another example where in the user manual, there are very specific line items as to the type of wound that the patient may have, whether it's a pressure ulcer, a diabetic ulcer, skin tear example, for example. But this also has another chart that also you score in terms of identifying what interventions are being put into place, whether they are interventions such as wound care or repositioning or creams or lotions as a preventive measure. So you really do want to make sure that you look in detail at this specific area in the OASIS user manual. You also want to include skin items in your own assessment tool that are not included in the HOPE, and have your own wound assessment policy. You should have a policy in place as to when wound measurements will be, when wounds will be measured, what the staging is of wounds example, and what the follow-up is from your staff, because you do want to make sure that your staff understand what your process is for assessing, monitoring, documenting, and treating wounds of all types within your hospice. Next, please. The medications section is not, there are no changes in the content here, but they do include scheduled opioids, PRN opioids, your bowel regimen, pharmacological, non-pharmacological, or multiple regimen. For pharmacological control or symptom management for patients taking opioids. The change here is that the medication section is included in the HUV visits. So the follow-up visits, it will be included. Next, please. And for record administration, this is the same process as in place for HIS in terms of making sure that everyone who has been involved in completing a section of the HOPE tool will need to document and sign this, not only when they have completed it, what the date of the completion was, and the sections that they completed. And then there is a final submission attestation that indicates that all items have been completed, not attesting to the accuracy. But this way you have your documentation, your record, and then your submission details. And the submission details is included in Chapter 3 of the HOPE user manual. And Jennifer did talk about the submission timeframes and the 4% reduction, future payment reduction. Once for any assessments that are over 30 days. And remember, they need to be completed and submitted and accepted within 30 days. So again, just as you do now, and as you have in place for the hospice item set, you want to make sure that you have a process for validating that or confirming that the HOPE assessment items that you have submitted are submitted in a timely manner. And just as an aside, the symptom follow-up visit will be included in your HUV or admission visit. So in other words, the time frame for completion and submission of that assessment will be included in the same time frame as the corresponding HUV or admission visit. And that is also outlined in the user manual. And again, just a reminder to ensure that you are registered in the iKeys system. Next, please. You need to know your baseline performance and measure it consistently moving forward. So start now. Know your iKeys through iKeys or Casper reports if you have them, as well as your Pepper once it's available. Again, be proactive in determining those clinical practice gaps with your current assessment of the patient and family status and needs, and regularly review your clinician documentation for trends of issues overall and with individuals. Evaluate to determine the issues now with the assessment process, whether it's in the clinician's understanding of the assessment that you currently have, the incorporation of the hospice item set, and then soon to be the HOPE tool into your comprehensive assessment items, and especially begin to train on those newer areas, aspects of HOPE that again are different from the hospice item set. You want to track and trend your refusal of services to determine if an update in the process needs to occur. This is just to make sure that all of your services are offered, and that you have a way to provide those services, and that you're communicating the interdisciplinary group and needs of the team in an efficient and effective manner with all patients. Making sure that clinicians have proper assessment completion training and evaluation of their competency. And this is not just related to the HOPE tool. This is related to the comprehensive assessment, completion of the assessment in all items in accordance with the conditions of participation, and ensuring that the patient's plan of care is in alignment with the comprehensive assessment, including the HOPE tool findings, so that the care that is being provided is, again, it's consistent and updated with each of these subsequent assessments. Next slide. You want to work closely with your EMR vendor and make sure that you're staying updated with HOPE and hospice quality reporting on the CMS websites and listservs, webinars and conferences such as this. Thank you for joining. And also your state and national associations who are also key partners in ensuring that you have the information that you need. And with that, I believe I'm turning back to Jennifer. Yes, I am, as we are in the home stretch, Jennifer.
Great. Thanks so much, Kim. And that was a great overview of what to look forward to in the HOPE tool. I'm just going to spend a minute or two to round us out here. The HOPE tool is going to be one of the larger vehicles that will move hospice to value-based programs. We're talking about pay for performance. And we know that CMS has been working on building value-based purchasing programs for several years now, because these programs are part of a bigger strategy to reform how not only is healthcare delivered, but how it's paid for. Value-based programs in testing have proved to be producing better care for individuals and upgrading better health for populations, and of course, lowering costs. So it drives providers to up the quality ante and be quality focused and driven in order to be incentivized for their quality outcomes. And all we have to do is look to the current home health value-based program to see where hospice is going to be several years down the line. The HHVBP was in a demonstration project first as a model to test it. This is pay for performance. Home healths are receive incentive upon their base reimbursement, depending on how well they do on a volume cohort of quality measure outcomes. And the value cohorts are equally distributed, meaning they're matched up with similar size in order for it to be a fair expectation and measurement. So if you are feeling daring and you want to look at the details of the HHVBP, I've given you a link here on this slide. What can you do now to prepare for value-based purchasing? Assessment is going to be a key. So this is a big change that's coming with Hope. But if you can train and harness assessment skills and competency and consistency and assure all of those things across the spectrum as you're implementing this Hope standardized assessment tool and its future offspring, you'll be in better shape once VBP comes to hospice. So that means that you're going to need to ensure competency of your staff, accuracy and consistency of assessment and completion of that Hope evaluation form, and efficiency without sacrificing documentation essentials. Also, you're going to need to know your patient population and your data. As Kim mentioned, there's a lot of data floating out there that you can harness in order to do a self-assessment of your current status. You need to have everybody on board, meaning everyone's dedicated, everybody's on board in order for you to lay the groundwork for becoming accustomed to what the VBP world offers. Focus on engagement with patients, empower your staff through training, and use technology, leverage technology and its power in order to, again, help you, but not turn everything over to technology so that you're losing the human touch, the engagement touch, the accuracy of assessment. Also, all of that will come together for you to provide high quality care to patients and families. And that's really the outcome that you want in a value-based purchasing system. All right, so I'm going to actually, before we go to questions, I'm going to ask Denise to sneak in here and talk about some upcoming education.
Absolutely. We do have some questions that hopefully we have a few minutes for. So just to cover this really quickly, this resource is in the slides for you along with the active links so you can check out these offerings. These are brand new. We haven't advertised these at all yet, so wanted to take this opportunity to share that with the group. We are offering a Power Up Your 2025 web series with several topics that hopefully are of interest to a variety. We have Compliance as Your Compass, which Jennifer Kennedy herself is going to be managing. We have Territory Mapping for Success that could help with your sales leaders and figuring out how to grow your agency. Setting a growth mindset that could really be for anyone in your organization. We're going to talk about effective orientations or onboarding processes, driving growth and improving outcomes through collaboration of your business development and clinical teams. And then lastly, avoiding some pitfalls and handling performance issues effectively. So that'll be all included in that web series, and it's going to be 2 webinars per week over the course of 3 weeks starting in November. So just 3 weeks away, actually. The other one that we're really excited to bring to you is this 5-star pathway, creating a path for excellence. And this is really about setting some standards for your visits that will help improve your CAPS survey participation and improve your star rating over time. So we're very happy to have a couple of guest presenters to help with this one. We're going to have a great time over 2 days doing a virtual workshop. I did not list that here, by the way, but this will be offered virtually. This would be great for any clinician, clinical leaders, administrators, COOs, CEOs, right, to really set the standard for how you want your patients to be seen and how that can impact your star rating over time. So join us for these, check them out, and feel free to email me if you have any questions about any of them.
Great, thanks, Denise. I'm going to stop sharing, and I think we have just a couple minutes for a few questions.
Yeah, and what I'm going to let people know is we actually got quite a few questions in here that we may not have time for. I will try to pull these questions and see if we can do maybe an FAQ possibly to do some of these that we can share later. But there were some questions around the HUV. There were actually several questions about this, like if the patient happened to be traveling, who would be responsible for completing that? Would there be a different hospice that might perform that if someone were outside of their home hospice's service area at that time. Any information the two of you might be able to share about that?
Yeah, so think about this in the same way as if you have a traveling patient who is now, they're needing their 15-day update to the comprehensive assessment, update to the plan of care. It's a similar situation. If you've contracted with a hospice in the travel area, you can very well have them do that hospice update visit while the patient is traveling. If you've decided to discharge, then that takes you out of the equation. The patient is now signing up with a hospice at the travel location. Then we're starting a whole new cycle, right?
And Jennifer, I would just add to that, the only other comment I would add is that, remember, if you are contracting with another hospice, it is your responsibility to ensure that those timeframes are met and that the documentation is complete and that it is submitted. So just keep that in mind.
Absolutely.
Question about EMRs. Is this on the EMR's side of responsibility to be doing the outreach to CMS and making sure that they're updating their products to align with this, or is CMS? I mean, tell us a little bit more about.
Okay, so yes, that's absolutely their responsibility. They've posted, I want to say about 2 weeks ago, they posted the final specs for the HOPE assessment tool. And so now your EMR vendors have the specs. If they have questions, then they need to go to CMS to have those questions answered. I believe there is a training associated with the specs as well. But it is your responsibility as a hospice to check in with your EMR to make sure that they are on a timeline and you know what that timeline is. So I hope that answers the question.
That was going to be my follow-up is what our attendees should do as part of this. So I think that was perfect. So let's maybe try to do one more. So this was a question about, is there a data item for a non-visit discharge with a patient death if the family refuses a home visit? I know that's pretty specific.
It is my understanding, Jennifer, I'll take this, you can add in, the in-person visit requirements are related to the admission and the HUV and the symptom follow-up visit. It's not specified in the guidance, in the user manual or in the guidance that the discharge assessment must be in person.
Correct.
Great. Well, that is the end of our time together. Like I said, I will go ahead and compile these questions and see if we can do a short FAQ that we could send out as a follow-up for everyone that attended today. Very much appreciate the interest in this topic and our wonderful attendance. As I mentioned earlier, the recording of this, once we've completed, will post to the registration site, and everyone that was registered will get a notification that that recording is available for review. I want to thank the two of you, Jennifer and Kim. Thank you so much for putting this information together. I know how much work it is and very much appreciate your effort and time. And I know that our over 500 attendees appreciate it as well. So thank you both.
One more item. Please watch our blogs because we are going to have a series of HOPE blogs throughout the rest of this year, early next year, leading up to implementation.
And I would just also say, again, just a reminder, keep checking CMS FAQs and websites and information. We certainly will share that, but that's where you may find some additional guidance to some of the questions that you also have as we get closer to implementation.
Right. And watch our compliance monitor, comes out every 2 weeks, and we do add in any updates on any hospice regulatory topic, including this.
Resources, resources, resources. Love it.
Yep.
All right. Thank you both. Everybody have a great rest of your day.
Thank you. Thanks for all you do.
Thank you.
Thank you.
Thank you.